Hello everyone. This is the last month of 2021. In December, without fail, we have this prosthodontics on Friday, which goes over the implant prosthetics step by step, advantages and disadvantages and the side effects in an easy to understand way. Today, we are going to talk about resolving challenging cases using implant bar attachment. We have Professor Ho Jung-bo of Busan University as a speaker. Hello. To join prosthodontics on Friday from Yangsan, Gyeongsangnam-do, you flew in here. Thank you. It is my honor to be with you, Professor Cho. Would you briefly introduce what you're going to talk about today? Today, I'm going to talk about the implant bar attachment to solve challenging cases. It is not something grand or new. It has been used for a long time, but with the development of materials and new ways of fabricating materials, and we try to find the new indications for that, the subtitle would be treatment using zirconia removable prosthesis. I believe it will be a good discussion using bar attachment, how to resolve challenging cases. We will have good tips from you. Thank you. If you are watching at the demo site right now, you will find the chatting window on the right side, and you can real-time communicate with us, leave questions there, and answers will be provided during the Q&A session. If your questions are adopted and discussed, Starbucks coupon will be sent to you. Your active participation is asked for. Professor Ho Jung-bo, let's get started. Hello, let me start the lecture. This is Friday afternoon, so I will do some exciting lecture. I'll try to do that. Thank you. I'm going to talk about how to resolve challenging cases using implant bar attachment, a treatment using zirconia removable prosthesis. I majored in, have long studied partial denture, and you're looking at many clinical cases of it. There are two types of partial dentures. One is moving and the other one is almost not moving. We learned when we were students, teeth and tissue can support movements for partial denture, so it is not moving. I'm sorry, the teeth-supported partial denture is not moving at all, but teeth and tissue-supported partial denture is moving, as the denture can move over gingiva. As you can see the pictures, if we use additional implants, there are three movements that can be controlled in the partial denture. One can be controlled, or we can increase factors like support, retention, or stability. So I believe you have heard implant partial denture quite a lot. I published the book Implant RPD with 4 classifications. The first one is a solitary type attachment is used. I believe a while ago there was a lecture on dental on this topic, an overdenture using solitary attachment, partial or full overdenture, next a bar using overdenture, partial or full overdenture, next a healing abutment is connected to an implant, a support in molars to make gingiva not painful. Next is a surveyed crown. We do a lot as it is covered by the National Health Insurance after placing an implant. So these are the 4 classifications. Among them, and I believe you heard many lectures on others, but today I'm going to focus on the bar type. I wrote many books and I have thought about this, how to advance my clinical practice. And in our university, when we do surveyed crown or when we use attachment, we studied the prognosis and we write clinical papers when it is combined with an implant. The prognosis seems to be very good as a conclusion. Still, we lack a lot of evidence, but it is getting more and more reliable procedure. This is not a patient. I get a lot of questions like this. My friend asks me how I do the prosthesis in this case. And implants are all destroyed here in many patients. Many implants were placed and part of them or most of them are destroyed and just a few remain. In this case, what do we need to do? 10 years ago, the patient was in the 70s without systemic disease, but after 10 years, over the 10 years, the implants fell out and the patient has diabetes and had stent surgery. We cannot place further implants in this patient. Can we deliver fixed prosthesis? A male patient in his 40s came to us from Daegu. The dentist who placed implants, I believe he had no choice because the patient wanted implants in an area where no bone was available. What would happen to this patient? Fixed prosthesis continuously failed, food impaction continuously occurred, leading to peri-implantitis and pus came out. He came to me like this after peri-implantitis treatment in the perio department. Should I provide a fixed prosthesis? A very challenging case. This is Professor Chung Chang-mo's slides 25 years ago. He used the word fixed removable prosthesis. It looks like fixed, but it is removable. It has fixed function, but it has the removable part for aesthetic reasons and to retrieve and insert it again. I remember still Professor Chung talked about it. So fixed function, that means we have enough number of implants and it is the same as fixed prosthesis in terms of the resistance to force and to stop it from moving. But we need to think about cleaning and ease of maintenance because in many cases, aesthetically, the soft tissue can get lost. So we can think about fixed plus removable. This is a famous paper. It talks about the vertical bone defect when it is 15 millimeters or more. It says fixed prosthesis should not be chosen. For 12.5 millimeters, you need to think about more, and for 9.5, you can do it. In the third picture, vertically it's 9.5 millimeter. However, horizontally there's a big deficiency. So when horizontal bone resorption is there using fixed prosthesis, it will result in protruded teeth. Is that a right approach? We thought about something new, especially when it is over 12 millimeters, the crown length. Crown ratio is very unfavorable. Many papers talk about mechanical complications like screw loosening or fracture of loose or peri-implantitis, and cleaning would be very difficult. In this picture on the right, it's not my slide, it's some other doctor's slide who doesn't want the name disclosed. There are enough implants, but there is a severe vertical bone loss and inappropriately fixed prosthesis was delivered. Cleaning can be done as it is formed like this, but food impaction occurs, especially overjet and overbite is provided, but the contour of the soft tissue is not formed. So the cheeks and anterior region and lips are sunk. So the patient complains he looks old. I believe the complaint can be legitimate if you look at the illustration on the left. If we place an implant just looking at the bone, the crown form, the emergence profile can look like the yellow part. It will invade the tongue space lingually, and on the cervical side, proper emergence profile cannot be made, making cleansing very difficult. With the shape of the prosthesis, we can approach it a little bit differently. I'm not talking about overextension of gingiva like a denture. We can place the denture base a little bit outwardly for proper emergence profile and artificial tooth. We can position the tooth in proper position and it helps cleansing and aesthetically more ideal prosthesis can be made. Especially when the vertical defect is quite large. Fix the prosthesis with gingiva is not that good. I'm not talking about this concept should be used at all times. When aesthetic and functional problems occur, we don't have to use the wide denture base like the existing denture base. We can think of a prosthesis with a little bit wider base for aesthetics and proper artificial tooth position. I understand that next lecture is on Magic 4. This case is from US Magic 4 site, and I'm using the slides citing the source. Like this, the bars are made and the prosthesis as well. Vertical and horizontal bone defect is very severe. Implants are placed without bone graft, like on the right picture. The denture base is a little bit extended and it is fixed. Magic 4 is tightened with screws, so cleaning is difficult. So there is a gap in the soft tissue part. You can see the gap between the prosthesis and gingiva. To clean the area with a water pick, we can do this. But if you look at here, even a healthy patient, when the patient is old, it is difficult to use water pick. And there are people who want to have a thorough cleaning. So this is precision not covering the denture base completely, not every day, but every week or every 2 to 3 days, the patient can retrieve it to clean it. With this backdrop, I chose the topic of today's lecture. This is from a book I wrote with a Japanese professor. As you have more implants, all the function would be done by implants, so denture base form would be different, as Dr. Cho would know it. For a full denture, the denture base would be wide, like a snowshoe effect, and it should have very good suction. However, if you use 2 implants, if support is achieved like the picture in the middle, the denture can be retrieved using the implant and the denture base doesn't need to be extended. With 6 implants, the denture base size can be further reduced. It is only for aesthetics and the positioning of the artificial teeth. For the left, for the RPD, as implant is placed, the support is provided and the buccal portion is cut off. If a function is provided by an implant, the function can be removed from the prosthesis, otherwise there can be complications from the prosthesis. Fracture or other problems. I want to emphasize today that the denture base is for aesthetics and positioning of teeth in the neutral zone and for ease of cleaning. I want to emphasize that this is not absolutely 100% right. We can use it in this case. This is the picture we had in our prosthodontics classroom. They are not very good. The crowns are too long for ease of cleaning and the holes are too big and the patient complains food impaction and they complain sunken cheeks. And if you do it like below, peri-implantitis may occur and it is difficult to use the intradental brush. Can you find a happy medium between these two? In this case, various complaints may arise, including the aesthetic problems, screw loosening or screw fracture, oral hygiene problem or food impaction, and other problems. Dentists are placing so many implants these days. Personally, you worked in a university hospital and our hospital is looking at 5 years in the future. So many failures from the private practices are coming to us. Many dentists do excellent surgeries and treatment for patients who are very satisfied. However, inevitable complications can occur and the problems will go to the local private clinics as well in 5 years' time. So Professor Chung Chang-hoon's fixed removable prosthesis can come very useful. and we try to further advance on top of it. So we try to combine the fixed and the removable functions. Before I finish, let me introduce this case. I will try to keep time. If you look this case on the right, at quadrant 2, 4 implants are placed. The patient came to me like this, labial version buccally. There is a big vertical space and the sinus lift was properly done, but we cannot really blame the surgeon. We need to solve the problem with fixed prosthesis as the patient wanted it, and we provided a temporary. We pulled it because we wanted to take a photo, but that much vestibule was visible. Toothbrush cannot go in there. The head of the toothbrush should go in to do the brushing. The patient had discomfort and the patient complains the deep wrinkle, and when it is more than 12 millimeters, complications can occur. Number 22 and 23 are within 12 millimeters, but distally it is over 17 millimeters. As you go distal, it gets bigger. With a fixed prosthesis, it will be very difficult to maintain. So I thought of a combination. This is made of gold, but assume it is made of steel. The front two is 12 millimeters, so fixed prosthesis with PFM to be covered by the National Health Insurance. And the distal two, I connected the bar to the implants. So they're strongly splinted. For the first two, the paths are not good and customs are used. PFM coping is connected to a bar. A fixed prosthesis for the two implants and the distally one attachment or two, and the zirconia removable prosthesis. As the bar provides retention, support, and stability, and it's not pressing down on gingiva. For various reasons, including aesthetics, I had to make gingiva for the patient. So we can think about using zirconia in a tiny partial area. I will explain it with some case later. Let's summarize with this slide. We have these prosthetic problems when we just place implants based on bone. By positioning the denture base a little bit, we can resolve the problem. So we use the old concept and we need a bar, round or dolder bar, and so many kinds. So for this purpose, we need to use a milled bar because the milled bar provides support and stability. In the past, we used to use friction, but now we have dedicated attachment which provides support and stability. So ultimately, we need fixed prosthesis, but still we can retrieve it. So we need to use a milled bar. For the attachment that can be used with the milled bar, there are locators and ADD-TOC. The ADD-TOC is developed in Korea. Each of them has merits and demerits, and they can be worn down. However, if the bar is fitting with the prosthesis and if it doesn't move, the retention of locator or ADD-TOC can last very long according to the study we conducted. Let me just skip this comparison data. As you know, a locator is used in a moving denture. If it is not moving, like a plastic inserted between the housing between the male and female parts, holes are made like this. I observe such cases from time to time. Holes are made in the bar, so a dedicated attachment is needed. ADD-TOC is used for bars only and cannot be used for anything else. Why holes are made in the locator? When a locator is completely attached to a bar, it is elastic, so it is pressed down. When you open your mouth, it detaches itself a little bit. The vertical force is directly applied to the plastic. So if you do not attach it properly, the vertical force will be concentrated on the locator. So the ADD-TOC attachment is having some gap, so that vertical force is not directly applied to it. It doesn't have a plastic part, and the zirconia is used to minimize the wearing, and it doesn't have tolerance for movement, so if the denture is moving, it doesn't work. Remember, it is the attachment for bars only. The advantage of it is that threads of a bar can be carved digitally, so the locator or digital TOC can be connected and disconnected as you wish. When it is worn, you can replace the attachment. No need to replace the whole bar. Gold used to be used, but today cobalt chrome is used, reducing the bar thickness to 3 millimeters, but if the bar is higher, the better. The minimum height was 14 millimeters, but it is changed to 9 millimeters. It is not based on scientific evidence, but materials advanced, so thin ones are very strong these days. Even if you have a cantilever, 9 millimeters is good enough. I'm talking of the vertical height. It has nothing to do with the cantilever. If you have a long cantilever, it should be thicker. Yes, it should become thicker. Thank you for the good question. In the past, we used the casting. Casting still is used. It is very difficult to carve threads using casting, and lab technicians are good at it. It can be milled as one piece. It used to be difficult, but now it is easy. Many doctors say, why do we have to do the milling? It is very complicated. Now it is as easy as making a custom abutment. It is milled but before polishing, so it is very good. If paths are not aligned, you need to use the multi-abutments, which is available from Osstem too. All of them, including the abutment and connection part, can be milled as one piece. With the digital technique, it is very good. We don't have to go through the putty index or measuring VD multiple times or milling using the survey. No such complicated jobs are required. As we design using software, screw holes can be made fitting the path, and spaces can be controlled as we want. So designing is done all in a software. If you create a zirconia prosthesis, the prosthesis itself can be made with the proper gaps. Because of that, I can use the zirconia removable prosthesis in front of you today. Digital development enables the use of materials, and when it is combined with the software, it is creating a new area in dentistry. I'll show you a case later. Only bars provide vertical support, and the attachment resists the falling out, so they should be separate. And stability is provided by the walls of a bar, so unless the patient pulls it out, it remains there. And for efficiency of chewing, it is just like a fixed prosthesis, and you can provide the occlusal points like in a fixed prosthesis. It doesn't work in 100% of the cases, so let me show you a case where it can work. This is the first patient I showed you during the consultation. The patient rejected the removable option. The patient said, I'm 40 years old and I don't want a denture. So I said, this is a fixed prosthesis, an aesthetic one, but if you want, you can retrieve it, pull it out from time to time. Then the patient accepted the option. So the patient is very satisfied now. Anyway, bars need to be made. Let me explain the concept. Instead of making alveolar bone using bone augmentation, just like we make maxillofacial prosthesis, alveolar bone is made using bar of the prosthesis. So I made it like this. The zirconia removable prosthesis is delivered to the patient. Supramargin is made and the patient can pull it out. After that, on the palatal side, a little bit of gap is created so that water pick can be used for cleaning. It is just like the removable prosthesis. However, we made gingiva and emergence profile is created Artificial teeth can be aligned like this. I instructed the patient to clean it using water pick and take it out once a week. And the patient said when it's taken out, there's some whitish thin film over the gingiva, which is cleaned using a toothbrush, and the patient is satisfied. He used to have sunken left upper lip. Now I created the lip support. A similar patient. There are so many cases that are good for partial cases. 3 years ago, the patient received the denture. Hard to believe. The abutments are all broken and clasped as well. And implants are placed like this. I'm not blaming the dentist to place them. Focusing on the available bone, it could have been placed better. It's hard to remove bone vertically and horizontally in this patient. The problem is 3 implants were placed, O-rings and clasps were used, destroying abutments, and because of the movement, occlusal points could not be provided. Pickup, scanning, and bar design. Virtual teeth are designed and a bar is designed. The prosthesis is fabricated. The bar is mounted in the mouth and the attachment is attached to the prosthesis. The patient can take it out using the attachment when necessary. So this is how it is applied in a partial case. Professor He, when you attach the attachment, is there anything to be careful about? Actually, in the next slide, it talks about that. I'm going to talk about how it is to be attached. You are a master, so you know what should come next. Sorry about my impatience. If you look at this case, I'm going to explain with this case. In the mandible, the bone is severely resorbed and we need to deliver a prosthesis. In this case, what is important here is that the bar should hold all the movements of the prosthesis, so the bar, frame, or prosthesis should be tightly integrated. As for other locators, in many cases we use spacers, so the spacer is not used here. No, we should use it. There should be a space between the attachment and the bar. Let me explain with a picture. Let's assume we make this type of prosthesis, then the prosthesis should not be moving. You have to make a gap where the attachment and the bar are connected. That is very important. I prefer to use rubber dam, about 0.2 micron. That is very good to serve as a spacer. Next, you have to make vent holes in the prosthesis to make resin come out. To attach it in the mouth, MDP containing self-adhesive resin cement needs to be used because it attaches to zirconia and metal pretty well. When you attach it, never have the patient bite on it, even though the occlusion is very well adjusted. If the patient bites on it, it will tilt toward one side. A surgeon should press it down with hands. After the attachment, can you adjust the occlusion? Yes. So it is the reverse sequence. If the patient bites on it, some gap can be created on one side. If you have a 2 locator implant, then you can have the patient bite on it. But in this case, if the patient bites on it and there is a gap between the bar and the prosthesis, all the force will be applied to the attachment, which is very dangerous. A milled bar over denture has been attached like that from before. I explained this just in case some dentists do not know about this. May I move on? Yes. Before I finish, I'll show you just 2 more cases. The patient is referred to me and it is painful to see this case. Very difficult surgery was done with fixed prosthesis. The patient kept complaining and fought with the dentist and got the refund. Such patients, when they come to me, do not trust me from the beginning. So it's very sad to watch such patients, and when I offer some options, they are suspicious and reject them. So I changed it a little bit. I put the attachment over the custom abutment. Do we have to use resin cement, 10 bond, and cement? I don't think so. I designed it to be attached to the 14 pi bar. I just want to show you this can be treated like this. The attachment is attached to the customs abutments and temporary is delivered. And the patient used it for about a month and very much satisfied. And this is the prosthesis I used. It is a fixed prosthesis. It looks like it, but the patient can take it out every week or every month. Endodental brush can go in, and the patient was complaining quite a lot before and suffered from peri-implantitis. Now he is happy as he can clean. I told the old lady that I give you the function that you can take it out and you can clean it to your heart's content. Providing a self-cleaning function to the patient is very important. Relying on the surgeon for all the cleaning may not work for the maintenance, so you need to give some responsibility for the cleaning to the patient. That was a partial case. Let's go to a full case. Am I going too fast? No. We have Q&A session after this. Okay. In this patient, it's a little embarrassing case. We didn't place the implants on the left. September 29, 2017. Our resident extracted teeth and did block bone augmentation. The oral surgeon tried, but in terms of aesthetics and the paths, it is not very good to place implants. As the structure was the problem, I was wondering what I need to do. Our resident asked us to place 2 implants where we can. And we did the RPD. If you look at the top right picture, there are 2 implants and a bar is made of gold and the friction is used to get retention. But it fell off after 6 months as they are worn down. It should not be designed like this. I think this is designed like this, believing that the bar will solve the problem. At number 17, it should be wrapped around. The clasp should be there, but it's not. So when the patient opens the mouth, it fell off. And the patient complained, and I was involved as a department head. So as I touched it, quadrant 1 all fell off. Implants should be placed with 1.5 to 3 millimeter distances, but implants were placed too close with each other and that led to peri-implantitis. So I told oral surgeon, I want to save the bone graft in the upper anterior, so place implants with whatever length or path. That's what I asked, and this is how they place the implants. The paths look aligned, but they are all different directions, and the length is 8.5. But one good thing is mandible is RPD. We need to look at opposing teeth. If they are very strong, 5 implants will not work. Even with all-on-4, for Koreans, if you do not balance the force, it will break down. You have to check the balance of force, and first I took the pickup impression, and the patient is complaining a lot. So this is what we do routinely, but what we are doing here is that we are determining VD to make a bar. This is a tip. Without this, the patient has to drive 2 hours to get the occlusal rim. So a bite tray is used, and the yellow part at the backside is cut off. And VD is measured at rest position. The bite is put in and silicone putty is inserted. The patient bites on it, and as I press it down and provide a rough CR guide, it doesn't have to be precise because this is to make a bar. CR is determined, and the pop-bow developed by our school is used to get the occlusal plane. Even though there's no occlusal rim, we provided the occlusal plane and VD information. Digital mounting can be done subtracting 3 millimeters. Immediately a bar is designed, so the patient can receive a temporary the day after impression taking. These are the fabricated bar and temporary. I wanted to connect all the bars, but there was no space, so it was not possible, and it is a little bit unstable, but still it is used until now without a problem for a year. Is the temporary made of ceramic? No, it is a milled resin block. So the quadrant 1 is a short arch up to number 6. as the cantilever should not be too long and only 2 attachments are put on. After sufficient occlusal adjustment, it is scanned, and the tempo is scanned. When you send the data, you get a very similar zirconia like this. So we could reduce 2 steps for the patient, and the patient is very pleased about the outcome. The patient suffered too much and the implant fell off. Now the patient is taking it out once a month because not all gingiva is covered and water pick cleaning can be done. So this is how it is used. So this is a fixed prosthesis, but it can be removed. Let me reach a conclusion. This is an old slide. Professor Chongchano allowed me to use this slide. This is professor's classification. What I'm saying here is not a new concept. Newly developed materials and attachment are used over the existing device, so it is a further improvement on the existing device. To reduce the complications, we came up with prosthesis that is in the middle. So we are not extending denture base completely, it is just slightly covering in the form. Let me read the conclusion. The attachment should be applied to rigid, not moving, removable prosthesis, and zirconia should be used in this case only, and you need to use dedicated attachment for this case. Zirconia can be used as it is for fixed prosthesis as well. Gingiva is added and cleaning and aesthetic functions are added. Fixed prosthesis is not always an answer. When bone loss is quite severe, fixed plus removable prosthesis can be used. This is a different perspective. I wanted to share that with you and Professor Jo In-ho. Thank you for the good lecture. I learned a lot today. I believe many dentists will call you. How can I deal with this case? Actually, now I get a lot of queries, emails, and questions, and it is my pleasure. I believe people will call you or communicate with you through SNS, and I hope you can answer some of the questions. You said the removable superstructure is made of zirconia. I believe zirconia has a lot of advantages and it looks good, but what do we need to be careful when we make a zirconia restoration? The attribution or disadvantages of zirconia? I missed that point. That's very important. Zirconia is very brittle. When you drop it, it breaks. I recommend that it is used for partial rather than full. When I use it for the full case, I train or instruct the patient not to remove it in the bathroom vanity without covering it with a towel. I tell them to remove it on the bed. One of my patients actually removed it on the vanity and dropped it, and it broke into pieces. Even though it is thick, it can break. As we use digital devices, in the past we had to take the impressions from the beginning, but I believe the information would be stored in the digital device. Can we talk about money? In our hospital, we charge a little bit more because we tell our patients that we can make it one more time for them. As we have the data, we tell them from the beginning they need to call us 2 or 3 days before they come to pick it up. Because I know the problem of zirconia. We now live in an iron age. Soon we will have ceramic age and then polymer age. And then all these worries would be gone. But in the next decade, zirconia will be used a lot. So we need to know it's a disadvantage. I understand. Thank you for the good lecture. Thank you. From lecture to questions, you've given us very good answers. Now, let's conclude Professor Ho's lecture here. And in real time, we received questions. Through Q&A, we will answer your questions. Let's look at questions that are posted on our site. Woo-sung says, Professor Jung In-ho, you look very nice today. Professor Ho Jung-ho, it's very nice to see you through Prosthodontics on Friday. SS asks a question. At the beginning of the lecture, you said hybrid prostheses can be fabricated using the remaining implants, but if you're not skilled prosthodontist, it is labor-intensive and it is costly and a lot of stress whenever I do the repair. Please keep that in mind. That's a good point. When we talk about a hybrid prosthesis, it is a metal frame with resin teeth using remaining implants, but due to complications, they break. When opposing teeth are strong, they break easily. That's why I use zirconia. I don't know about the cost. Is it expensive? The treatment cost. How much is it in your university, Busan University? Our university hospital, the treatment cost is very expensive. You'll be surprised. An implant is about 3 million won, so it's more than double the price of private clinic. Learned from other dentists who ask similar questions in terms of the lab cost. I don't think we charge much higher than general overdentures. As far as I know, in Busan area, we charge about 30% more. I'm not sure about Seoul area. Okay, this type of information will be included in the next lecture and I will compare the costs. Thank you. Thank you. H0, when fixed prosthesis is used in the mandible and removable on the maxilla, how do we ensure the cleaning and oral health care? So when you instruct your patient, how do you train them? And it is delivered by a dentist, and you cannot just forget about it after delivery. You need to make patient use it for a long time. It's our responsibility. How do you train? As I mentioned during the lecture, there should be 1.5 to 2 millimeter space between gingiva and the bar. It is a milled bar, so you can insert interdental brush into the space and the patient holds a mirror and I instruct the patient to clean it under the bar, and if the patient is not skillful at that, I don't send the patient home. Is the bottom flat? Yes, the milled bar is flat. You mean the bottom? It should be flat or convex. It should not be concave. You need to specify that in the order you place with the lab technician. You need to instruct the lab technician to make it that way. That is the most important thing. If that goes well, there is only one problem, which is fracture when you use a zirconia prosthesis. For cleaning, bar cleaning is the most important thing. For the superstructure, do you clean it once a week with a toothbrush and toothpaste? For zirconia, you can use anything, just like cleaning the fixed prosthesis. You should not use toothpaste with an abrasive, but you can use it on zirconia without a problem. Okay, I understand. Professor Paul, your explanation is fascinating and you have very good voice tone. I was yelling. I think you make a very interesting lecture. Let's go to the next question from DIFT25. How do you deal with the fracture during the fabrication of zirconia denture? Fracture during fabrication? I believe the problem is fracture during fabrication, during milling. If a certain area is very thin, it can fracture. But if it is 1 millimeter or thicker, it'll be okay. I think the question is if it is fabricated and if it is broken while pulling out, can you repair it? No, you have to make it again. It's just like the fixed prosthesis. We use the monolithic zirconia, and if it breaks, we have to make it again. We have to get rid of the fixed concept of denture. A denture has movement and should be relined, so resin is used for that. And zirconia is held by the bar. Someone called the head asks, what do you think of checking occlusion in the mouth and attaching the attachment extraorally? If you need to restrict the movement, fitting it extraorally would be more appropriate, as a zirconia denture may not be taken out. That's really a very good question. It can happen, I believe. The attachment can be attached at a lab, but the attachment will be worn down and that needs to be replaced by a dentist. So you need to make vent holes to attach it, but it can be attached in the lab and it will fit pretty well, as we already fitted it on the bar and the prostheses are made on the bar. At the beginning, the patient may not be able to take it out, and then you can use the ejector. It is zirconia, so if you tap on it, it can come out. And then clean the excess resin cement. And then if you put it on and off a couple of times, then you can easily take it out. Using too much cement would not be good. Exactly when you use it excessively and there is no vent hole, cement cannot be removed, then you will not be able to remove it. And the resin cement has very strong adhesive power. How strong the retention of the attachment and how can I replace them? The retention, I didn't show you the retention study data. Locator has very strong retention. Too much. 3 or 4 of them need to be connected to be stable. Then the patient will not be able to remove it. And the locator has different colors. It is a very good attachment, but it has that problems. But ADD-TOC has less retention of the attachment. For stability, 3 or 4 need to be used. For a full mouth case, to replace a locator, you can pull out and insert the plastic, but ADD-TOC connector part is worn down. To replace it, unscrew it with 35 Newton centimeter and tighten it with 35 Newton centimeter. The housing can wear too, but housing needs to be replaced. It is designed to last a little bit longer, but it depends on patient. All the attachments can wear. When you explain it to a patient for the replacement, do you say it should be replaced every 6 months or every year? According to the manual, it lasts 2 years, but in our hospital, when we use a bar, it can last pretty long. But when we explain it to the patient, we say it can vary depending on a patient. People can take it out every week or several times a day. I wouldn't know, so I tell the patient it should be replaced every 6 months or a year. If they agree to that, I provide the treatment. And you need to tell the patient in advance the replacement would cost money. Otherwise, the patient may complain. Of course, you need to charge that service. So we need to explain it in advance. Next, compared to normal implant overdenture, does it cost much more? For general overdentures, as you said before, it is made of plastic and the lab cost seems to be low. If it is made of zirconia, I believe the lab cost is the same as Magic 4. So I think it is about 1.5 million won. In terms of the lab cost for an overdenture, in our area, it costs 1 to 1.2 million won. I'm not sure about in Seoul. So the overdenture, it is based on 4 implants. Bar is used. So the lab cost, yes, the lab cost. The treatment cost may vary from hospital to hospital. So Is the lab cost 1.2 million for 4 implants, the bar and plastic overdenture? I asked the lab that I'm having business and it said it's 1 to 1.2 million. But as I understand it, the Magic 4 from Osstem is about 1.5 million won, an additional 200,000 won for the attachment, but I'm not sure. How much is ADD-TOC? ADD-TOC is Korean product, very cheap. The Locator is like 150 to 160,000 won, and ADD-TOC is like 60 to 70,000 won. Thank you. I want to know about the complications like fractures. I cannot say there's no complications, but if you know the principles and understand the functions, they can be prevented. So if you understand the principles, the complications can be greatly reduced. From Yeonji-shi, thank you, Professor. Between bar and clip and the bar and magnet, what need to be considered for longevity and maintenance? I prefer the latter. When a magnet is attached to a milled bar, the patient for MRI procedure needs to remove it. So do you remove it for the patient? What do you think? For the MRI procedure, if it is related, the magnet should be removed. I use the magnet quite a lot. Magnet can be buried in the bars, reducing the vertical height, which is a benefit by 2 to 3 millimeters, but it is weak. But I prefer to have a retention support and stability. Of course, magnets can last longer, but at the beginning, the retention is rather weak. That's the disadvantage, so I used it a lot in the past, but these days, I use locators or ADD-TOC. Next, Professor Cho, you have a lot of fans. Would you scroll up, please? Scroll up. Further up. When you mill a bar, how do you form the threads? When a bar is milled, the equipment, including the locally produced one, the threads are directly carved if you use a digital technique. If not, casting can be done. There is a plastic sleeve with threads. It is cast in pattern resin or something else. If you cast, oxide film is formed, so it is not clear. So you do the taping. With the tapping, the threads are formed. As you know, if 2 or 3 threads are engaged, it is good enough. Usually the threads are 3 millimeter deep, so 8 or 10 would be formed. If you cut it, you will find 2 or 3 of them are engaged, and it is very stable. It doesn't have to be very precise like between implant and abutment. So we need a lab which has a lot of this kind of experience and know-how. Once this was booming, so all labs casted the bar. You can find old technicians very good at this, but now everyone moved to fix the prosthesis, so this is not done anymore. But now it's coming back again because it can be easily done with a digital technique. That is right, because of the digital technique. Also, AxoCAD or other software provides bar designing tool, which is excellent. If you receive the ADD-TOC specification about forming the threads are in conformance with international standard ISO locators as well. Otherwise, FDA approval cannot be obtained. If a dentist is doing the milling in his own clinic, I found one in Changwon. I was really surprised. Thank you for the good lecture. I am keenly interested in ADD-TOC listening to your explanation. As I understand it, in the case of a milled bar, inter-arch space should be sufficient. If not, solitary type needs to be used. Can we use the ADD-TOC as a solitary type? No, never. because ADD-TOC itself is developed for bars. It should be used only for the denture that is not moving. You can use a locator here. Can I use it when implant paths are all different? Yes, you can. It's a very good question. Yes, you can place implants with certain distances, and you don't have to be too much under stress for placing them. But due to mental problem or others, bone grafting cannot be done in a certain patient, and you can place the implants where the bone is. That is the big advantage of this. Milled bar can be splinted even though the paths are not aligned. That is a big advantage. Very good question. The next question is from Jung Yun-soo on YouTube. How do you instruct the patient to do the hygiene control when the patient uses this prosthesis? You already mentioned it, right? The interdental brush under the bar. It is the same as you take care of your natural teeth. Are there many different ADD-TOCs like locators depending on retention? ADD-TOC has 3 types, but over time, 30% of the retention goes down in all of them. Instead of plastic, spring is used to reduce the wearing. So you can use medium or low, whatever. It doesn't really matter. Because they're different at the beginning, but after about a month, they become the same level. Yes. In the case of ADD-TOC, if connector part is loosened, you can tighten it. It rotates and retention can be obtained. There are 3 balls that continuously scratch, and if it is rotated, it moves to the unscratched part, so retention can be increased that way. If it is done a lot still, in that case, you need to replace it. There are different types. It is not important from my experience. Konchinam, thank you for the good lecture. Awesome. Easy to understand answers to the good questions. Thank you for the questions. Thank you. This concludes the Q&A session. Professor, we received a lot of questions. Thank you for the good answers. Dr. Hu's lecture seems to be popular, and I would like to thank the audience who participated in the chatting in real time. We will do the lucky draw. Winners receive coffee coupons. Lastly, now there are many dentists who are studying by watching this program, your colleagues and seniors and juniors. So before you close, would you like to give us a word of encouragement, if I may? If you look at the lecture today, the fundamental remains the same, only the materials and the manufacturing have been advanced. So follow the principles, and if you understand the materials and the manufacturing method, you will be able to reduce the side effects considerably. Following the trend and market situation, we tend to develop bias, so we tend to forget about good things we had in the past. Try to look back on the old things and incorporate new methods. Don't be obsessed with one thing. There's no correct answer. I want to say this again. I'm not saying this is the correct answer. This is one of the options. So this is one more available option that you can use. I believe there are many options because there are many such cases where fixed prosthesis is very challenging for implants. In that case, fixed removable can be a very good option. So you are saying we need to follow the principles for the treatment and implant placement. Our social life and politics need to follow the principles as well in order not to create problems. The same goes for dentistry. Thank you for being with us. Prosthodontics on Friday. Thank you, viewers. How was the lecture delivered by Professor Ho? So we talked about tips to address challenging cases using implant bar attachment. I hope it has been a very beneficial time. If your questions are not answered, it will be provided later. The last episode of Prosthodontics on Friday this year will be in the form of panel discussion. Next Friday, we will talk about magic points of Magic for Prostheses, which will be delivered by Dr. Seo Jung-woo and Dr. Chun Se-young. Please look forward to it, and thank you very much for staying with us until the late hour. Thank you.
자, 교수님, 감사합니다.
감사합니다.
감사합니다. 수고 많이
감사합니다.
하셨습니다.
교수님.
네.